So welcome back, everyone. So the title is To Treat or Not to Treat, basically talking about the management of first onset seizure and epilepsy. So a bit of outline of how the talk will go. First, a bit of introduction, then we'll talk about the factors to consider prior to considering therapy for first onset seizure. Then we'll talk about the risk factors for recurrence following first onset seizure. And then we'll talk about the effect of anti-epileptic therapy on the risk of recurrence of seizures following first onset. And then a bit about the American Academy of Neurology guidelines pertaining to this topic. So bismillah, a bit of introduction. So the discussion about treatment following first onset seizure should always include the following considerations. First, what is the chance of a second seizure? So if the chance of a second seizure is low, intuitively, you don't want to start the patient on anti-epileptic therapy necessarily, and vice versa. Second question you'll ask yourself following a patient presenting a first onset seizure is, what are the consequences of having another seizure? So if a patient is, for example, a truck driver or a taxi driver, the consequences of having another generalized tonic-clonic seizure for him are immense, as opposed to someone else who is bedridden and doesn't have much to do. The efficacy of treatment should also be considered in preventing subsequent seizures. So if we have very efficacious therapy, so it would be worthwhile trying most patients following first onset seizure. But if we have less effective therapy, it may not be worthwhile starting on treatment following first onset seizure. And then finally, what are the potential side effects of therapy? So if you have drugs that have a lot of potential side effects, you may not opt to start treatment following first onset seizure. And then we'll talk about what do you mean by first seizure. In general, first seizures are classified into provoked seizures and unprovoked seizures. Provoked seizures, as the definition implies, are seizures that are provoked by factors that are not necessarily related to epilepsy. For example, alcohol withdrawal seizures, hyponatremia-induced seizures, drug toxicity seizures, and so on and so forth. And then the unprovoked seizures can also be further classified into so-called acute symptomatic seizures, which are the seizures that, the definition varies, but most people agree that are the seizures that happen acutely following a cerebral insult, such as a stroke or intracerebral hemorrhage or meningoencephalitis, within usually 7 days. These are a lower risk for seizure recurrence compared to the following one, which is the remote symptomatic seizures, which is, again, the same thing. The patient has a cerebral insult, the same ones I mentioned, but they go on and to have a seizure, but months or years later after the cerebral insult. So not in the acute term. And these ones have a higher chance of seizure recurrence as opposed to the acute symptomatic seizures. And then we have seizures that are associated with epileptic syndromes, usually in pediatric populations such as juvenile myoclonic epilepsy or childhood absence epilepsy and other types of syndromes. And then we have the unidentified so-called cryptogenic seizures at the bottom. So what are the factors to consider following a first onset seizure? You see a patient in the ER, he's presenting with a first onset generalized tonic-clonic seizure. What factors should you consider before starting therapy, whether you're going to start or not? First thing is it a provoked or unprovoked seizure? That's the first question you should ask yourself. If a patient has alcohol withdrawal, which is a provoked seizure, if he is presenting 100 times with that seizure in 100 different occasions, you're not going to necessarily start him on anti-epileptic therapy if the treatment for that is withdrawing the provoking factor. So provoked seizures in general are a generalized tonic-clonic seizure. So therefore, if you see someone who's presenting with a focal seizure, with few exceptions, or focal onset with secondary generalization tonic-clonic seizure, then you might think that this is probably an unprovoked seizure as opposed to a provoked seizure. Then the second thing you would consider prior to considering therapy for first onset seizure is the type of the seizure you're dealing with, and whether it's focal or generalized. As I said earlier, if it's focal, unlikely to be provoked, but sometimes focal seizures may not need therapy necessarily. For example, kids who present with first onset focal seizure in the context of Rolandic epilepsy. It's an epileptic diagnosis, however, it's known to be benign and less likely to occur. And if it occurs, it's unlikely to cause limitations in the patient's life. However, this depends on the patient, as some patients can have cortical dysplasia or other cerebral lesions that may require therapy, even after first onset seizure. Third thing I would look at is the patient's age, because incidence of new onset epilepsy is a bimodal distribution, as in many other diseases. And it tends to be most common in the children population, especially neonates, and prior to puberty, and also in the elderly. Elderly usually present with unprovoked seizures, and they don't have idiopathic seizures. So they're not genetic syndromes. They're secondary to cerebral lesions. Even if the imaging is negative, it's usually due to underlying cause. And the stroke is the most common cause of seizures in the elderly. Therefore, many of these so-called first unprovoked seizures in the elderly are in fact remote symptomatic seizures. So they're remote seizures in the context of a symptomatic cause, such as a previous stroke or cerebral insult. Moreover, in general, when an elderly patient presents with first onset seizure, it should be considered a focal seizure until proven otherwise, because it's unlikely for an elderly to present with first onset seizure for the first time as a generalized epilepsy syndrome. And I see this mistake been happening many times where people, elderly people presenting with first onset seizure, and it's probably a focal disconnect seizure, and people write to consult saying a patient with absence epilepsy. Absence doesn't usually happen in the elderly for a first time. Then you will consider whether it's an acute versus remote symptomatic seizure. As I stated earlier, acute symptomatic seizures are defined as the seizures that happen within 7 days of a cerebral insult within that time frame. And they're less likely to occur over the years compared to remote or delayed symptomatic seizure, according to many studies. According to this one study here, shows the risk of recurrence of acute symptomatic seizure following a previous cerebral insult, such as stroke, is only about 30%. Whereas if they've had a delayed onset seizure, so more than 7 days after the onset of stroke, usually months or years later, they're more likely to recur, more than 70% chance of recurrence with first onset seizure as a remote symptomatic seizure following stroke. Now, a bit of prognosis and trends. Most of you guys might know this. The risk of recurrence following first provoked seizure is very low. It's hardly 10% or less. And the risk of recurrence following a first unprovoked seizure is higher than, obviously, the provoked seizure risk. However, it's still quite low following first unprovoked seizure. It's less than 50% still. The greatest risk of seizure recurrence is in the first year. It's about 30%. It's a front-loaded risk. And then as you go on, the risk becomes slower, and it's about 50% by the 5th year, according to different studies. Several studies have shown, as I said, with long follow-up, that most seizures, if they occur within the first year or 2 years. This graph here highlights this fact. You can see here, do they see my cursor, by the way? Okay. So as you can see here, it's a front-loaded risk here, and the, oops, sorry. On the x-axis, you see the different time in years. This is 1 year till more than 5 years. And then on the y-axis, you see here the percentage of risk of seizure recurrence over the years. And you can see there within the first year, most patients are likely to recur. If they're going to recur, they're going to recur within the first year. And then after that, the risk of recurrence increases by small margins only to reach about 50% by the time there's more than 5 years follow-up. So if they're going to recur, people with first onset seizure, they're going to recur in the first 2 years following that seizure. So what are the risk factors for recurrence? Well, there are many studies done on this matter. First study by Hauser in 1982. They looked at these risk factors, and many risk factors indeed, and they found that these are the most consistent in their study. First is an abnormal EEG, and not any abnormal EEG. If there's generalized spike wave discharges, epilepsiform discharges on the EEG. Second, they found in their study positive family history of epilepsy in siblings. Now, this risk factors per se is not a consistent risk factor in different more recent studies. However, the third one is also important. The history of previous neurologic insults. So they've had previous stroke or cerebral insult of any kind. They are more likely to recur with seizures following first onset seizure. So remote symptomatic seizures is a risk factor for recurrence. These risk factors were associated with increased risk of recurrence for more than 60%, according to the study. They also found that for patients with remote symptomatic seizure, if they presented with status epilepticus in this study, or Todd's paresis, who had previous history of acute symptomatic seizure, they had higher risk of seizure recurrence. So that doesn't mean that if you present with acute symptomatic seizure, you're more likely to have recurrence of seizure, but it means that if you're presenting with delayed onset seizure following a previous old cerebral insult, and then go on to have an acute symptomatic seizure, and if you had a history of acute symptomatic seizure before, then you're more likely to recur again. Acute symptomatic seizure has low risk of recurrence in this study, about 25%, as I mentioned, and treatment is not required for these people. What about seizure recurrence risk in children? Where children are more likely to have idiopathic or genetic seizures than adults as the first onset seizure, and they're more likely to be due to syndromes. Studies on children with first unprovoked seizure found that abnormal EEG, so again, that's another consistent risk factor for seizure recurrence, following first onset seizure, which is abnormal EEG. Usually that means epileptic activity, not just non-specific slowing. And then remote symptomatology is the second factor. So if they've had insult, or if they've had mental retardation or autism, or developmental delay. And then seizures during sleep, that's because of the connection with frontal lobe epilepsy in children. And history of febrile convulsions, usually complex febrile convulsions are more important. And if they are presenting with thought paresis implying focality, these were higher risk factors for seizure recurrence in some studies. Now, what is the effect of treatment on seizure recurrence? If you say, okay, is it worthwhile starting treatment on someone presenting with first onset seizure? Is it going to alter their long-term prognosis, prevent them from having epilepsy, or reduce the chance of seizure recurrence over the next few years? Well, let's have a look at this. Well, according to the first seizure trial, they found that in the untreated group, they only had 2 years follow-up, by the way, and in the untreated group following first onset seizure, the risk of seizure recurrence was about 50%. So people who went on to have a first onset seizure, they have a 50% chance of having another seizure in the subsequent 2 years. Whereas in the treatment arm, the risk of seizure recurrence was only 25% over the next 2 years. That means that there's about 50% risk reduction in people who receive treatment in the following 2 years. So there appears to be benefit, at least in 2 years' time. Therefore, they concluded that treatment does reduce the risk of seizure recurrence. Then let me ask basically everyone here. So why are we not using then treatment following first onset seizure in general? We're looking for these risk factors. If there is an absolute risk reduction, we can use it pretty much for anybody, right? But the problem is this. According to more recent studies, which had longer follow-up, more than 5 years, they found the same result or similar results in the first 2 years. However, immediate treatment did not, so that means immediately treating after first onset seizure as opposed to delaying treatment for subsequent seizures, did not influence the long-term prognosis or seizure remission rates. So more than 3 years later, they found that the onset of epilepsy or seizure recurrence is the same, whether you treat following first onset seizure or you delay your therapy until second or third seizure occurrence. So this timetable here shows you, it's from a meta-analysis showing different study groups with different patient populations. Showing you here the short-term therapy over 1 or 2 years. There's a big difference between the treated arm versus the untreated arm following first onset seizure. And you can see the percentages are half, and in some cases even less than 1/5 the recurrence risk of the treatment of the untreated group. So there appears to be a significant benefit if you treat them early on following a single seizure, as opposed to if you don't treat them. In the short term, the follow-up was only 1 or 2 years in these studies. However, if you extend your follow-up to more than 3 years at least, you start seeing that there is absolutely no difference, whether it's statistical or clinical, between the treatment group and the delayed or deferred treatment group following second or third seizures. So in this case, for example, they had almost exactly the same percentage of seizure recurrence more than 5 years later. So there is no benefit in the long term, whether you're going to start treatment following first seizure or you defer your treatment to subsequent seizures. Now, important point is this is in general for whether they have risk factors or not. Having risk factors for seizure recurrence make you more likely to benefit from therapy if you start treatment early on. And this is a question that many people would ask is, whether if the first onset seizure that the patient presents with was a single seizure versus they presented with multiple seizures or even status epilepticus. Is there a difference in outcome in terms of seizure recurrence later in the future? No. Okay, studies have shown that whether you're presenting with a first onset seizure as a single seizure or multiple seizures as the first onset seizure, there is no difference. Still, that's why the definition is still one seizure if it's within 24 hours. So now this is the summary American Academy of Neurology guideline. So they talk about the risk of recurrence is greatest in the first 2 years, as we saw. Therefore, there's an apparent benefit with immediate treatment of patients with first onset seizure, first unprovoked seizure, not provoked seizure, in the first 2 years. However, this apparent benefit pales in comparison to the effect that there is no benefit over the long term when there is follow-up more than 3 years, according to studies. And patients with prior, these are the epilepsy risk factors now. Patients with prior cerebral insults or lesions, abnormal imaging, that's important. EEG with epileptiform discharges and nocturnal onset seizures had the greatest risk of seizure recurrence. Studies have been consistent on these risk factors. The duration of first seizure and whether it was status epilepticus, as I mentioned, had no significant influence on future seizure recurrence risk. Now, these are the risk factors again, just for memorization's sake. Patients with prior brain lesion or insult, so remote symptomatology. Second is epileptiform abnormality on the EEG. Thirdly, significant brain imaging abnormality, whether it's CT or MRI. Obviously, MRI TLE protocol with thin cuts to the temporal lobe is more desirable after a first onset seizure to rule out any epileptogenic lesions. And then nocturnal onset seizure to imply possible focal frontal seizures, which tend to cluster and recur. Now, you'll see here all the different risk factors that have been studied in different studies, and the ones in red are the only ones that have been consistently shown to increase the risk of recurrence by more than 2-folds. So what about EEG? We talked about the EEG abnormality and increasing risk of recurrence, but by how much? What about if there was just slowing or non-specific changes? Well, according to this Dutch group, they did a 2-year study on the EEG abnormality and seizure recurrence risk following first onset seizure. They found that EEGs with epileptiform discharges following first onset seizure had more than 80% chance of seizure recurrence, as opposed to those with non-epileptiform abnormalities such as non-specific slowing, only about 40%, and it helps risk stratify to low risk those people who had normal EEG following first onset seizure. So if you have a normal EEG following first onset seizure, you have only about 10% chance of seizure recurrence, according to this study. Of course, the EEG is more sensitive, done within the first 24 hours, and the routine EEG detects epileptiform. This is the sensitivity of the EEG, is about 30%. And it becomes more sensitive, you do it more prolonged, sleep deprived with provoking maneuvers and stuff. What about imaging? CT is less sensitive than MRI. CT in general detects about 10% lesions following first onset seizure, whereas MRI detects up to 30%. And in one study, they found that CT only detected 12 out of 28 brain lesions detected by MRI. The things that CT misses usually are cortical dysplasias, low-grade gliomas, things that are subtle that the MRI only picks up, and mesotemporal sclerosis as well when it's subtle. So now balancing the odds, let's talk about in summary what's going on. When it comes to whether to treat or not to treat first onset seizure, certain factors have to be considered. First, you need to know if you are dealing with a provoked versus unprovoked seizure. If it's a provoked seizure, now it's an anti-epileptic issue. It's dealing with the underlying cause. If it's an unprovoked seizure, then you need to know if there are associated risk factors that increase risk of recurrence for such patient. And you can tell that by doing some investigative, such as EEG and MRI, and clinical history and physical exam methods. Thirdly, once establishing that the patient has a high risk of seizure recurrence following first unprovoked seizure, you need to balance the potential side effect and the socioeconomic factors with the potential benefits of treatment that's given to the patient. Excuse me, to the patient. So you don't want to give necessarily a treatment to someone who doesn't have many risk factors, and you might cause them renal failure or other. But on the other hand, if a patient has higher risk of seizure recurrence, you may want to treat them because they're more likely to endanger their lives without treatment. So this is the slide before the last. This algorithm here shows you how to deal with a first onset seizure. First, you establish whether you're dealing with acute symptomatic seizure, correct the underlying abnormalities, or provoked seizure. Then you just correct the underlying cause. If you're dealing with an unprovoked seizure, then you go on to do an MRI and EEG. If the MRI and EEG are abnormal, then you may want to start first line anti-epileptic therapy according to the patient you're dealing with. If the imaging and the investigative studies are all normal, then you may consider to defer the therapy following first onset seizure till more information becomes apparent. And EEG is not a one-off thing, it's a continuum. You need to do several EEGs if you're suspecting this patient has a higher chance of recurrence until you get, because it's a low sensitivity study, especially when it's done routinely. So in conclusion, the decision to treat or not to treat after first onset seizure is dependent on several factors, like we mentioned. Early treatment seems to reduce the risk of seizure recurrence in the short term, that is 2 years. However, it does not seem to alter long-term prognosis of epilepsy over longer follow-up following that, up to 5 years. Therefore, potential short-term benefits of treatment should be weighed carefully with the potential risk and side effects of medications in each patient, and should be individualized as such according to their respective risk factors for recurrence. So at the end of the day, it's a case-based physician choice decision. Okay, thank you.